మేడం స్టార్ట్ చేద్దాం. మేడం మీకు క్లియర్ వినిపిస్తుందా మేము మాట్లాడేది?
వినిపిస్తుంది.
ఓకే మేడం, విల్ స్టార్ట్ మేడం.
ఓకే.
గుడ్ మార్నింగ్ ఆల్. టుడే with a little bit issue with మేడం స్లైడ్స్ స్లోగా మూవ్ అవుతున్నాయి.
ఇప్పుడు మూవ్ అవ్వలేదు.
సరే స్లోగా చేయండి. మీ పీపీటీ కొంచెం విత్డ్రాల్ లో ఉన్నట్టుంది, విత్డ్రాల్ సిండ్రోమ్ వచ్చినట్టుంది మీ నెట్ కనెక్షన్. సరే మేడం, విల్ స్టార్ట్. గుడ్ మార్నింగ్ ఆల్. టుడే డాక్టర్ లక్ష్మీ రాణి Takkelapati is the head of the Department of Critical Care Hospital. He is going to talk on alcohol withdrawal syndrome, Benzodiazepines and Beyond. Actually, it is a topic of gents, but madam wants to do this topic. I don't know. I request Dr. Rani madam to start the presentation.
Good morning, David. Is there anything gents topic, ladies topic nunda?
అంటే ముందు కొంచెం జెంట్సే కదా పెడతారు, వాళ్ళకే విత్డ్రాల్ వస్తుంది కదా, మీరేమో వార్నింగ్ ఇద్దాం అనుకుంటున్నారేమో.
అంటే ఫర్ ఆల్ యువర్ బెనిఫిట్ మేము చూస్తాం కదా, అందుకనే.
అలాగే మేడం, అలాగే మేడం, వెల్కమ్.
చాలా కలర్ఫుల్ గా ఉన్నాయి మేడం స్లైడ్స్. చాలా కలర్ఫుల్ గా ఉంది స్లైడ్స్.
అంటే మరి విత్డ్రాల్ వాళ్ళకి అన్ని కొంచెం అలా కనిపిస్తాయి, ఆడియో విజువల్స్. అది anyway, I thought rather than having a routine topic, I've gone through this topic recently. Thought I'll present this today. So this is actually a review of lots of topics, thousands of topics over a period of 10 years. So they've reviewed the evidence base, taking free and how to diagnose and management of alcohol withdrawal syndrome. So we know it's a common problem all over the place. So it like as per World Development Report, alcohol related disorders affect 5 to 10% of world population each year and 2% of global burden. So as per ICMR estimation, there are 62 million alcoholics in India. Like that was 6-7 years ago. So it says that's equivalent to population of France. So by now, maybe we have defeated many more country population in alcoholism. Maybe in Andhra Pradesh itself, maybe we defeat a small country population. So alcohol dependence is the second most common psychiatric disorder next to depression. So the signs and symptoms of alcohol withdrawal are because of alcohol-induced imbalances in the brain. It results in excessive neuronal activity if the alcohol is withheld. So taking into time frame, so when the alcohol cessation happened and how we see the symptoms. So if it is stopped for 6 to 12 hours, minor withdrawal symptoms like insomnia, tremors, anxiety, GI upset, headache, diaphoresis, palpitations, anorexia, nausea, tachycardia, hypertension, these can occur if withdrawn stop for 12 to 24 hours. Auditory and tactile hallucinations can happen. And if it's for 24 to 48 hours, withdrawal seizures, generalized tonic-clonic seizures, and if it's more than 2-3 days, it's a delirium tremens with seizures, hallucinations, disorientation to space and time, agitation, all these can happen. The delirium tremens is an emergency condition. It can be fatal. It needs to be immediately treated. So for mild, they don't need to be hospitalized. For severe forms, they need to be hospitalized and treated. So how do we assess alcohol withdrawal syndrome? So it's an objective assessment of severity is by a tool called Clinical Withdrawal Assessment for Alcohol, a revised scale. It's a 10-parameter scale to quantify the severity, and it's also used to monitor the withdrawal and medication adjustment accordingly. So in this tool, like the parameters are like nausea, vomiting, tremor, paroxysmal sweats, anxiety, agitation, tactile disturbances, auditory disturbances, visual disturbances, headache, and the other one is orientation and clouding of the sensorium. So all these, except for the last one, that's orientation and clouding of sensorium, that has 0 to 4 points on the scale, and the others have 0 to 7. That's why it got total score of 67. And if it is like 0 to 8, it's a minimal or absent withdrawal. And if it's 9 to 15, moderate, and 16 or more, severe withdrawal. So this tool is used when they do the detoxification in rehab centers, and accordingly they are. David, you all can see where you are.
Madam, AWS assessment దగ్గర
Sorry?
ఇప్పుడు pathophysiology వచ్చింది మేడం.
Pathophysiology ne ippudu. I'm on the pathophysiology. The scoring tool I didn't put on the screen because I checked it later and I got it in my mobile. I can share the that scale thing. So pathophysiology of alcohol withdrawal syndrome, we need to know this, then only we know how the medication works, and then we know why it happens, not just because they didn't have alcohol, it reduced their kicking. It's not like that. What happens in the central nervous system is the pathophysiology. So it's caused by interruption of the constant exposure of central nervous system to alcohol itself. So the long-term alcohol consumption affects the brain receptors, which undergo adaptive change in attempt to maintain the normal function. So what happens is decrease the brain GABA. So we know GABA is an inhibitory neurotransmitter. So it increases the GABA level. So inhibition is reduced, and receptivity also, and activation of glutamate system to hyperactive. So GABA is a inhibitory transmitter and glutamate is the excitatory transmitter. So alcoholics, GABA is decreased, and at the same time glutamate system is activated, and there is hyperactivity in the absence of alcohol. Hello, can you hear? And also in chronic alcohol exposure, GABA receptors become less responsive, and higher alcohol concentrations are required for suppression of this GABA receptors. So this is called tolerance. So they need more and more alcohol to function the GABA receptors. Alcohol is an NMDA receptor antagonist. So decreases the excitatory tone. But in chronic alcohol, there is upregulation of glutamate to maintain the CNS homeostasis. And symptoms like autonomic overactivity are expressed as tachycardia, tremors, sweating, neuropsychiatric complications like delirium and seizures. Increase in dopamine levels in the CNS also cause of autonomic hyperarousal and hallucinations. So there's a reduced GABA, there's glutamate, and there's the NMDA antagonist increases dopamine. These are the causes for hyperactivity, the autonomic disturbances. So to diagnose something as alcohol withdrawal syndrome, we have to have evidence of recent cessation or reduction of alcohol after previous dose regular use. So if we see somebody who stopped a week ago or something, then probably we can't that, or a month ago, but he used to drink before that, maybe we can't call that as alcohol withdrawal syndrome. We have to have evidence of recently taken and regular chronic heavy alcoholic. That's when we call it alcohol.
Madam, ఒక్కసారి హోల్డ్ చేయండి. మేడం ఒక్కసారి హోల్డ్ చేయండి. ఎవరిదో మైక్ ఆన్ చేసి ఉంది, రిపీటెడ్ గా బ్యాక్గ్రౌండ్ లో వాయిస్ వస్తుంది. డేవిడ్ సార్ ఎవరైనా అందరూ మ్యూట్ చేయరా?
మాట వినపడుతుందా శీలు?
అవును సార్.
నాది మైక్ ఆఫ్ చేసింది.
మీరు కాదు సార్, మేడం వరలక్ష్మి మేడం ఆన్ చేసింది. Madam, please start.
Continue చేయండి మేడం.
Yeah, as I said, to call it as a alcohol withdrawal syndrome, there has to be a clear evidence of recent cessation or reduction of alcohol after previous high dose regular use. So if we see somebody in our hospital or ICU, if they said that they have stopped it 3 months back or 6 months back, but they have drunk like for years, but still we can't call it as alcohol withdrawal syndrome. Like in smokers, we can't say that effect is being carried forever. Anedi kaadu. Alcohol withdrawal syndrome lo, there has to be a history of a very recent alcohol ingestion. Maybe last few days, put a regular dose they were taking and stopped it suddenly. Then they show all these hyperactivity or anxiety hallucinations. Then we call it as alcohol withdrawal syndrome. And symptoms of alcohol withdrawal can't be accounted for any other medical or mental disorders. That means we have ruled out all alcohol-related hepatic encephalopathy or psychiatric disorders or medication history, drug abuse, and drug abusers, and they have the withdrawals in symptoms as well. We can't get mixed up with alcohol withdrawal syndrome. So we have to rule out all these things. So relevant tests are to be done to rule out all these and then call it as alcohol withdrawal syndrome. And for that, you need to have thorough, proper history, amount and frequency of alcohol intake, and also do clinical examination to see if there are any other signs of any other problem. Like if you see IV drug abusers, you may see lots of marks on the body, or if it is a liver disease patient, you may see the some signs and symptoms on the body in the patient. So all these clinical examination we have to do thoroughly. So when it comes to pharmacotherapy and the goals of detoxification is to provide a safe withdrawal from drug dependence and enable the patient to become drug-free or alcohol-free, and provide the withdrawal that's human. We can't be like so shrewd, like tying them up, or I mean, sometimes restraints when it is delirium tremens we have to use, but not like in society, not like keeping them locked up or tie up. All these things may not work. So they may become more alcohol withdrawal symptoms may become more obvious, and protect the patient's dignity. Prepare the patient for ongoing treatment for the dependence on alcohol or other drugs. So they can't just go for I mean, we see many people, they go for a month or detox or rehab, but they have to have ongoing treatment. They have to have, as inpatient, they start on something, but they have to continue with smaller dose of something or the other to keep it going, to get rid of withdrawal. So it can be done as outpatient or inpatient. We many times we see inpatients only, outpatients or mild cases, they get outpatient treatments, but moderate to severe cases we do see in the hospital. So the cases need to be treated as inpatients. So older age, past history of delirium tremens or alcohol withdrawal seizures, and severe withdrawal at the initial assessment, comorbid medical or surgical illness, presence of dehydration, electrolyte imbalance, or deranged liver enzymes, and the presence of any brain lesions. For all these, they need to be treated as inpatient. And coming to the drugs of alcohol withdrawal, so the ideal drug used for alcohol withdrawal syndrome should have rapid onset of action, longer duration of action, and wide margin of safety, and metabolism not completely dependent on liver function, and absence of abuse potential. So, and many of the drugs what we use are liver metabolized in the liver, and at the same time most of the alcoholics, they may have some liver function problem. So we have to see which one is suitable for them and start that. And what are the types of things we use for treat the alcohol withdrawal syndrome? And historically, previously, they used to use alcohol itself to to reduce the severe symptoms, but that's been stopped. That's not advised these days. The other groups are like benzodiazepines, anticonvulsant drugs, adrenergic medication, barbiturates, baclofen, and few new drugs. So we're going to that. As I said, alcohol should not be used to treat the withdrawal. If we use that, it's like a alcoholic person thinks it's acceptable. So they may do more on purpose to get some more alcohol. So that's not the solution. So we shouldn't use that. And it also causes toxic effects on liver, pancreas, bone marrow. And it's inferior to benzodiazepines and chlordiazepoxide. So coming to benzodiazepines, they're safe, effective, and preferred medication for treatment of AWS. It has a cross tolerance with alcohol and modulate anxiolysis by stimulating GABA A receptors. It prevents agitation and alcohol withdrawal seizures and delirium tremens. So as I said, it has cross-tolerant agents with ethanol. The commonly used benzodiazepines are chlordiazepoxide, diazepam. These are the long-acting. We need long-acting ones for withdrawal, so to treat withdrawal. And lorazepam and oxazepam are intermediate acting. So actually, lorazepam is the preferred drug for alcohol withdrawal syndrome patients because it has no active metabolites and metabolism not fully affected by liver problem patients. And that's why it's a preferred drug for liver dysfunction patients as well. And short-acting benzodiazepines, there is a risk of rebound symptoms. So for immediate like seizure control or something like that, we may use, but we have to use the long-acting as well soon after the short-acting. And coming to anticonvulsant drugs, we all know they prevent seizures and reduce craving for alcohol, and they block the igniting effect in the brain cells. Kindling means like initiating or igniting, beginning like that. So they block the kindling effect on the brain cells, and there's no abuse potential for anticonvulsant drugs. They reduce the mood disorders of alcohol withdrawal syndrome. There are less sedative effects compared to benzodiazepines. And the preferred drug is carbamazepine. So it's usually used in multiple and repeated withdrawal problem patients. Valproic acid, it's effective, but more side effects. Side effects are like somnolence, GI disturbances, confusion, tremor. So with all this, it gives us a confused picture whether the patient is getting better or worse, because the alcohol withdrawal syndrome symptoms are more or less similar to these. That's why this is not a preferred drug, valproic. Gabapentin, similar to GABA with low toxicity. So there are some studies comparing gabapentin and lorazepam in randomized double-blind studies. They're equally effective in mild to moderate cases. And the other one is vigabatrin. It irreversibly blocks GABA transaminases, but it takes a longer time to start working. It takes more than 3 days. So like in severe forms, you can't start this alone because it takes too long to work. Adrenergic medications, alpha-2 agonists, clonidine, that improves autonomic symptoms of withdrawal. So it can be used as adjunct to benzodiazepines, particularly as outpatient cases. And barbiturates, they have cross tolerance to alcohol and can ease the withdrawal symptoms, but they have very narrow therapeutic index, so they are not preferred drugs to treat alcohol withdrawal. Baclofen, actually, this is a good one. Baclofen act through GABA B pathways. So it reduces a craving for alcohol, and it's comparable to diazepam in reducing the scores, assessment scores. So, and also like when we give baclofen along with benzodiazepines, the requirement for benzodiazepines is reduced. And the newer drugs which are tried in the alcohol withdrawal syndrome are NMDA antagonist ketamine. It's well tolerated in low doses and reduces benzodiazepine requirements. And the last one is dexmedetomidine, used in emergency setup as an adjunct in the treatment of alcohol withdrawal syndrome. So in our hospitals, when we see alcohol withdrawal severe form, we do give lorazepam, but probably we can try many patients. They become like hyperactive and very irritable. Probably we can give like some small dose of baclofen, or we can try small dose of dexmedetomidine or ketamine in addition to lorazepam. Because these things like they can't give as out for outpatients, ketamine, dexmedetomidine, all these they can't give as outpatient, but we can use in severe forms in the hospital. So when we see somebody with delirium or seizures because of alcohol withdrawal syndrome, so the things to do is put them, give them lorazepam IV first and monitor them and do all the investigations to see if they are in hypoglycemia or look for electrolyte imbalances and LFTs and RFTs. And we have to monitor them in HDU or ICU. And if there is any suspicion of any intracranial problem, we have to do imaging, because usually if they are in seizures, obviously we do CT brain to look for any pathology. And the other airway protection and supportive treatment, all that we do anyway in ICU. So other adjunctive supplements for alcoholics and thiamine, even like when we give glucose, if it is hyperglycemia, we have to give thiamine first. Give thiamine. Do we give 100 BD or 100 TID? I think they said 200 to 300 per day. So right, thiamine and the supplements like magnesium, niacin, all and multivitamins, they are usually malnourished. So we have to supplement with vitamins and minerals. Recurrent hypoglycemias they may have, so glucose monitoring and healthy diet. So these are the things, adjunctive therapies. The conclusion is, before we call something as withdrawal syndrome, we have to take proper history and rule out all other medical conditions and prevent seizures, address malnutrition, and public awareness programs. But public awareness, who's doing? Government has to do all that. What is it doing? No. So there's a lot more alcohol-related problems in the society. And we see a lot more alcoholics in the hospital. Thank you.
Madam, public promotion to increase consumption or reduce consumption, because alcohol is a life for the
public awareness అన్నాను సార్, మీకు అన్ని ప్రమోషన్లే ఇస్తాయి. నేను అన్నాను పబ్లిక్ అవేర్నెస్ ఆఫ్ ప్రాబ్లమ్స్ డ్యూ టు ఆల్కహాల్.
మరి ఇన్కమ్ ఎక్కడి నుంచి వస్తుంది మేడం? ప్రాబ్లమ్స్ గురించి
మళ్ళీ బకరాలు ఉన్నాం కదా సార్ ట్యాక్స్ కట్టడానికి.
ఒక చేతిలో ఇస్తుంటారు సార్ అలవెన్సెస్ అన్ని, ఒక చేతిని ఒక వైపు నుండి లాక్కునేస్తారు.
బ్లాక్ డేవిడ్ గారు,
సార్
బెస్ట్
One
ట్రీట్మెంట్ ఏంటి ఆల్కహాల్ విత్డ్రావల్ కి అయితే ఐసీలో
మేడం చెప్పారు కదా
ఏమిటి?
అవేర్నెస్.
కాదు, నేను ఒకసారి మిస్ అయ్యాను అది.
నేను కూడా మేడం ఒక క్వశ్చన్ మేడం, వాట్ ఈస్ ద డోస్ ఆఫ్ థైమిన్ ఇన్ ఆల్కహాల్ రిలేటెడ్ విత్డ్రావల్?
సార్ నా క్వశ్చన్ అవకాశం డేవిడ్ గారు, అంటే అబ్రాడ్ లో కొన్ని సార్ డేవిడ్ గారు సారీ ఇంటరప్ట్. అబ్రాడ్ లో కొన్ని ఐసీలో ఆల్కహాల్ విత్డ్రావల్ రెడ్యూస్ చేయడానికి దే విల్ గివ్ అంటున్నారు, మళ్ళీ ఆల్కహాల్ ఇస్తారు. చెప్పారా లేదని
ఇన్ ఇండియా ఆల్సో
అది చెప్పాను. అండ్ దట్స్ నాట్ ఎ సొల్యూషన్. అండ్ దే సెడ్ షుడ్ గివ్ ఆల్కహాల్ ఫర్ విత్డ్రాల్ అని చెప్పారంటే, బికాస్ ఐ హావ్ ఆల్సో సీన్ డ్రగ్ అడిక్ట్స్, ఆల్కహాలిక్స్. I used to see అక్కడ కొంచెం ప్రిస్క్రైబ్ చేసి కూడా ఇచ్చేవాళ్ళు. బట్ దట్స్ నాట్ ద ఐడియల్ థింగ్ టు డూ. ఎందుకంటే దే ఫేక్, దే మాలింగర్ మోర్ withdrawal symptoms to get more of that. అందుకని they think it's acceptable and they continue to consume. అందుకని not safe. We are causing further more problems. అందుకని వద్దు అని అడ్వైస్.
మీ వాయిస్ మధ్య మధ్యలో కట్ అవుతుంది మేడం. ఫైనల్ గా ఆల్కహాల్ విత్డ్రావల్ కి ట్రీట్మెంట్ లోరాజిపామ్ అండ్ బెంజోడైజెపిన్స్.
Lorazepam and benzodiazepine ka sir, and you can
further ga what is after?
You can add
Vitamins,
baclofen,
thiamine.
you can add small dose ketamine, you can add small dose like dexmedetomidine. ICU లో ఉంటే ఇవన్నీ కూడా ఇవ్వచ్చు టు రెడ్యూస్ ఆటోనామిక్ డిస్టర్బెన్సెస్.
మేడం cover this వెర్నిక్స్ ఎన్కెఫలోపతి ఇన్ దిస్ టాపిక్.
వెర్నిక్స్ ఎన్కెఫలోపతి ఎందుకు వస్తుందంటే వాళ్ళలో థైమిన్ డెఫిషియన్సీ అది ఉంటుంది కదా, అందుకని వాళ్ళల్లో వెర్నిక్స్ ఎన్కెఫలోపతి వస్తుంది. వాళ్ళల్లో ఆల్కహాలిక్స్ అందరిలో థైమిన్ 200 mg ఫస్ట్ బోలస్ ఇచ్చేసి తర్వాత 100 BD రెగ్యులర్ గా
Actually, for our neurologist is putting 600 milligrams IV TID for 48 hours. Later is changing to 200 milligrams IV TID next another 1 week, followed by 100 mg BD. Yeah.
అంటే అడ్వైస్ థింగ్ ఐ హావ్ సీన్ ఇస్ 200 to 300 mg పర్ డే అని చదివాను. సో మేబీ అంత
సైకిల్ గా ఎంత ఇస్తారు? డేవిడ్ చెప్పినట్టుగా 600 ఇస్తారు.
600 mg TID 2 days. Later they are reducing to 200 TID.
న్యూరాలజిస్ట్ అలా ఇస్తున్నారా డేవిడ్?
అవును సార్, న్యూరాలజిస్ట్ అలా ఇస్తున్నారు.
నెక్స్ట్ 1 week ఇస్తారా?
Next 200 mg TID for 5 days to 1 week. Later అంటే sufficient 100 mg BD.
So
what about loading dose?
మీరు చాలా హై లోడింగ్ డోస్ చెప్తున్నారు కదా. మా దగ్గర మామూలుగా ఐసీయూలో అయితే న్యూరాలజిస్ట్ నాట్ అడ్వైస్, బట్ ఐ థింక్ వీఆర్ యూజింగ్ 200 to 300 లోడింగ్ డోస్. శ్రీనివాస్ ఎంత?
అంతే మేడం, సేమ్ 2 to 200 లోడింగ్ డోస్.
Even neurosurgeon also advising the same dose, 600 mg TID for 2 days. Particularly alcohol withdrawal seizures with Wernicke's encephalopathy, these cases.
Okay.
Madam, he said the ketamine also is advised, but ketamine causes hallucinations and it may worsen, no?
Ala, అంటే along with benzodiazepines as adjunct, a small dose. Even మనం మామూలుగా కెటమిన్ ఇచ్చినప్పుడు కూడా టు రెడ్యూస్ ద సైడ్ ఎఫెక్ట్స్ వి గివ్ మిడాజోలామ్ ఏదో ఒకటి ఇస్తాం కదా, కెటమిన్ అలోన్ ఇవ్వము. దీంట్లో వెరీ స్మాల్ డోస్ దే సజెస్టెడ్, బట్ అంత ఎక్కువ స్టడీస్ లేవు.
What is the dose of haloperidol, madam, when patient is very aggressive? not responding to lorazepam.
5 to 10 mg నా అలాంటప్పుడు షార్ట్ యాక్టింగ్ ఐవి షార్ట్ యాక్టింగ్ బెంజోడైజపైన్ ఇచ్చుకోవచ్చు. సెరనేస్ హాలోపెరిడోల్ అవన్నీ కూడా దే టేక్ టైమ్ టు వర్క్ కదా.
Yes, madam. The first dose is 5 milligrams IV
5
slow
milligrams.
bolus Penargan.
అలాగే ఇస్తాం 5 milligrams.
And patient is not responding after half an hour. Again, give one more dose of 5 milligrams. 2-3 times we can repeat, madam.
నేనైతే if they don't get under control, we usually give either lorazepam or midazolam. ఏదో ఒకటి ఇచ్చేస్తాను.
Yes, madam. If patient is
irritable.
Yeah, if it causes severe QT prolongation, sudden VTBF.
Yeah.
So must be careful while giving haloperidol.
Yeah.
Any questions? Srinivas, Satish. Hello.
Madam. Good morning.
Morning, Satish.
Cheppana.
Madam, withdrawal and when do we say? Like one dose last night taken, next day there is a withdrawal?
If it is not regular high dose, just after one dose.
Because most of the times this happens with us. Occasionally we'll drink overnight. Next day, do we face this withdrawal symptoms?
No.
అది withdrawal కాదన్న hangover.
Regularly taking వాళ్ళకి అంటారు withdrawal అని. They have been taking regularly high doses, even if they stop for 12 hours, 6 hours or 24 hours. తర్వాత when they have this restlessness, insomnia, agitation, all these, then you call it withdrawal, but not after just one day party తర్వాత వచ్చేదాన్ని అనరేమో. Maybe you have a heavy head and you have a hangover, but maybe that's not called withdrawal.
Okay. Okay.
Treatment ఏంటి మేడం hangover కి?
అది మీరు చెప్పాలి డేవిడ్. అది అబ్బాయిల టాపిక్.
మీరు అన్ని ప్రిపేర్ అవ్వాలి మేడం అన్ని.
మీరు అన్నారు కదా ఇది అబ్బాయిల టాపిక్ అని.
మరి అయినా కూడా ట్రీట్మెంట్ మీరే చెప్తా అన్నారు కదా.
అంటే తెలీదు. చపాతీలు
చెప్పాలి
మరి ఇంట్లో మజ్జిగిస్తారో లేకపోతే వెల్ హైడ్రేట్ చేస్తారో కాసేపు నిద్రపోని పడుకోమంటారో నాకు తెలియదు. చెప్పాలి అది.
పొద్దున్న రౌండ్స్ కల్లా ఇరిటబుల్ గా పొద్దున్న రౌండ్స్ లో ఇరిటబుల్ గా ఉంటే విత్డ్రాల్ స్టార్ట్ అయిందండి మేడం.
మధ్య చాలా మంది చాలా పార్టీస్ ఫొటోస్ పెట్టేస్తున్నారు కదా.
అదే దాన్ని పొద్దున్న రౌండ్స్ లో ఎలా ఉన్నారని దాన్ని బట్టి కేటగిరీస్.
That is only hangover, right? Headedness, nausea. అదే అకేషనల్ గా నెలకు ఒకసారి తాగితే అలాగే ఉంటుంది.
యాక్చువల్గా బేసిక్ వాటర్
రోజు తాగాలా?
రోజు కొంచెం తాగితే ఉండదేమో కదా డేవిడ్?
ఏముండదు. ఏంటుండేది?
ఆల్కహాల్
విత్డ్రాల్. మేడం చెప్పారు కదా, ఆల్కహాల్ విత్డ్రాల్ డ్యూ టు హెవీ కన్జంప్షన్ ఆఫ్ ఆల్కహాల్ అండ్ సడన్ విత్డ్రాల్, నాట్ డ్యూ టు రెగ్యులర్. వెస్టర్న్ కంట్రీస్ లో 2 pegs అవి వెరీ కామన్ అండ్ వెరీ దే విల్ టేక్ రెగ్యులర్లీ డైలీ. That will not cause any withdrawal or any hangover or anything.
Madam, one more thing. Can I ask? Like some patients presents with one episode of seizure overnight, and when you take the history, nothing is contributory except that he is having alcohol. So 2-3 times, my neurologist telling that withdrawal causes seizures and binge also causes seizures.
Yeah, binge also cause that's why binge. Maybe they are taking not that much, but maybe taking regularly and a binge drink on one night. may cause, and also it's because of maybe they'll have alcohol ketosis, maybe they'll have alcohol osmolar gap ketosis. All these things may happen because alcohol itself can cause lot of changes in the body homeostasis. Avanni kuda cause kaవచ్చు kada binge drinking toti. That's why they end up in seizures.
Any differentiating factor? Because
that may not be because of alcohol withdrawal.
yes, madam. Okay.
The వాళ్ళకి we need to rehydrate them and seizure control avanni chesin tarvata maybe that's not like typical withdrawal syndrome. Withdrawal syndrome ki they need to have continuous medication for quite some time.
Not that, madam. So one thing is like, is there any time duration like occurrence of seizures and cessation of alcohol? If it is immediate or if it is long term, like maybe after 2 days, 24 hours, 34 hours, something like that, anything seizures happens, or it can happen immediately.
Okay. ఇదిగోండి ఇది చూడండి ఒకసారి. టైమ్ ఆఫ్ అపియరెన్స్ ఆఫ్టర్ సెసేషన్ ఆఫ్ ఆల్కహాల్ యూస్. ఇదిగోండి
24-48 hours.
సెసేషన్ తర్వాత విత్డ్రావల్ సీజర్స్ రావచ్చు, జనరలైజ్ టానిక్ క్లానిక్ సీజర్స్.
Okay, madam. Okay. Got it, madam. Thank you.
David, anything? Hello?
Hello, any questions?
And sometimes no, we unnecessarily attribute this to patient is normally drinking alcohol regularly. He stopped alcohol for more than 15 days, 20 days. Still, we tempted to call it as alcohol withdrawal syndrome.
That's why, Satish Garu, that's why I said you can't call that as alcohol withdrawal syndrome.
Yes, madam. So it is easy to put a diagnosis so that we can feel happy.
That's why we have to rule out all other things unless they are in continuously alcohol intake just for last 1 to 5 days మధ్యలోనే ఈ ప్రాబ్లం ఆపేశారు అండ్ ఇవన్నీ వచ్చినాయి అంటే we can attribute to this, and that's ruling out all other causes in this slide. Otherwise, if they stopped months back or month back, he's been okay, but last 2-3 days అవుతుంది అంటే you can't attribute that to alcohol withdrawal.
Thank you, madam. Thank you.
Adding to
what are the sir, adagandi.
Adding to Satish sir, sometimes they may present with severe LV dysfunction also, madam, the alcoholic people.
That's alcohol related cardiomyopathy or something maybe they are developing.
Yes, madam.
I know some of the like 1 or 2 well known like family friends used to be doctor, developed alcohol related cardiomyopathy, severe LV dysfunction, had to have CRTD and transplant to that level because of alcohol. So if they are going into alcohol related cardiac issues, they have to be very careful and to be followed regularly. They may end up in severe cardiomyopathies and may end up in assist devices or transplants.
Every alcohol patient needs to be ruled out other conditions, madam, like pancreatitis, cirrhosis, CLD.
If you have labs suggesting any of those, we have to rule out any previous admissions with any of the liver disease problems or anything. Because alcohol related, alcohol induced, you have pancreatitis, you have liver disease, so many cardiomyopathies, so alcohol related, so many issues. So we have to rule out all those. But if there's a clear-cut evidence of that he's been drinking just regularly, heavily till midnight, and for some reason didn't drink for a day or two and showing all these signs and symptoms, then you call it withdrawal syndrome.
Madam, why somebody is drinking so much, you'll not get any withdrawal or any hangover, but somebody will get only for 1 or 2 drinks a day? What is the reason, madam?
Because they have acclimatized to that, and their brain cells in CNS, there's a upregulation of some things and decrease in GABA and all those things. So neurotransmission changes occur over a period, sir. So chronic regular alcoholics, maybe they might have started with small quantity intake and gradually gone up to this level. So their CNS is adjusted to do the normal daily activities. So if it is stopped for a day or two, their upregulation or inhibition, all those things will go down and they become more aggressive.
Not only CNS, madam, some people will develop acute severe pancreatitis with one binge of alcohol. Some people having lots of binge of alcohols frequently, they don't develop even liver problem, cirrhosis or pancreatitis, anything.
Yeah, true. That's true.
Madam, is it necessary to do CT scan for all alcohol withdrawals?
If they develop like seizures and all that, probably we do it to rule out any other problem. We don't know.
Because majority alcoholics, they drink and they fall frequently. So there are high chance of developing subdural hematoma.
Yeah, that's
these
why
things.
unconscious or seizures, all these, anyway, we do CT brain to rule out any other things.
Yes, madam. Because we had one patient, madam. He is,
Huh?
sir?
పర్లేదు మీరు చెప్పండి డేవిడ్. ఊరికే సతీష్ వాళ్ళు ఎంత ఇస్తున్నారు టైం అడుగుదామని మర్చిపోయాను.
సార్
మీరు ఆల్కహాల్ విత్డ్రాల్ వాళ్ళకి టైం ఎంత ఇస్తున్నారు అని.
రొటీన్ సార్ 200 TID అంతే.
There is one patient, sir.
మోహన్ రావు
వైజాగ్ లో ఎక్కువ ఇస్తున్నాం సార్, మరేంటో గానీ
వైజాగ్ ఎక్కువ ఇవ్వట్లేదు, కేర్ లో ఇవ్వట్లేదు, అందుకే అడుగుతున్నాను. కేర్ లో ఇవ్వట్లేదు, సతీష్ వాళ్ళు ఇవ్వట్లేదు, ఇక్కడ మెడికల్ ఎంత ఇస్తానని అడుగుతున్నాను.
నుంచి బీడీ ఇస్తున్నాం సార్ ఎక్కువగాను.
We are dependent on oral tablets, sir. Etivan, Librium.
సార్ మేబీ మేడం ఆ స్కేల్ చెప్పారు కదా, స్కోర్ అదే ఆల్కహాల్ విత్డ్రాల్ స్కోర్ ఎక్కువ ఉన్న వాళ్ళకి ఎక్కువ డోస్ అవసరం పడుతుందేమో. ఏం మేడం?
Oh, don't know. It depends on how malnourished they are. Like some people, though they are alcoholics, they do take enough supplements or enough healthy diet. I don't know how they decide on the dose time in. But minimal dose అయితే 200 to 300 per day ఇవ్వాలి. And other minerals and electrolyte supplements and other multivitamins అవి కూడా ఇవ్వాలి, because maybe they are not taking enough diet. But 500-600 doses అయితే మేము ఇవ్వలేదు. I have to see. అడగాలి మా న్యూరాలజిస్ట్ ని.
Madam, we had one case, madam, recently. That patient is a software engineer in US, is working in artificial intelligence, and is almost like a scientist. He is owning his company and preparing all the artificial intelligence programs. He is an alcoholic, and at home he had alcohol and he fell down in washroom. A small laceration on the head, but otherwise he is fine. He is okay. Because of alcohol, mother thought he is under alcohol influence. Some dressing was done, and patient okay for 2-3 days, but little bit drowsy. Third day he become unresponsive and thrown seizures status. Then brought to the hospital, anti-seizure medication given, and we did a CT scan, showed the large, massive subdural hematoma with midline shift. So immediately we decompressed, and one pupil is dilated, decompressed, and patient responded very well, and is frequently is coming with whenever he is taking alcohol. Within few hours he is developing seizures, and again is 2-3 times he admitted again. Hello.
Hello, David. Already pre-existing seizure disorder unda?
లేదు, ఆల్కహాల్ విత్డ్రాల్ సీజర్స్ వస్తున్నాయి ఆయనకి ఫ్రీక్వెంట్ గా.
Maybe he should stop and continue on anti-epileptic medication kada and see.
But he won't stop. Anti-epileptic medication is taking, but he is taking continuously night. He is to do that work from home, but whole night he used to drink, and morning he comes with seizures.
Ayyo.
అది రెగ్యులర్ గా ఆయన ఇది. Thank you, madam. Very nice presentation, very informative, and
Very
thank you
useful
all.
lesson.
It helps.
Thank you, madam.
And
Thank you, sir.
we'll close the session.